we practice in AIISH, we get many calls from our old students or the concerned faculty or staff who are working in the other institutions, asking for how to assess individuals who are having tinnitus, audiological assessment, because this area is not much explored till date, and there are lots of confusions as in how to plan the assessment of individuals who are having tinnitus. So in my lecture, I'll try to focus on how we are going to assess them and why do we need to assess the individuals who are having tinnitus and what are the special assessments that are required to be done in such individuals. So I thought I'll just brief about the pathophysiology a bit with respect to these things, but since it is schedule is delayed, I will not go in detail at all. So as Dr. Rajeshwari and Dr. Ajit shared in the previous sessions, the tinnitus can be generated due to problem in any part of the auditory system. That thing you should have to remember. It can be generated due to any part of the auditory system, be it external ear, middle ear, inner ear, or your higher auditory pathway up to auditory cortex. So keep that point in mind. And as discussed before, it can happen due to problems in the inner hair cells, outer hair cells, or it can be explained using the discordant dysfunction theory, which was explained by Dr. Ajit. It can be again due to limbic and autonomic system, nervous system involvement also. So this also I'm not going in detail again. So what causes due to inner hair cell? How inner hair cell can be a reason for tinnitus generation? And this was, how outer hair cells can be a cause for generation of tinnitus. So here I can say that, the type 1 and type 2 fibers what are present in the cochlea. If there is a mismatch in the output due to malfunction in the outer hair cells, what happens is the stimulus that goes to the higher center will maladapt, and what happens, your higher cortical structures will already have some maladjustments, and it will try to boost the gain, and that boosting can result in tinnitus generation. And discordant dysfunction theory was explained by Dr. Ajit. There is disinhibition at the dorsal cochlear nucleus. And neurophysiological model again was explained by both of them. So I'm not going in detail at all. So here you have to remember the reactions what is generated is one of the major key for generation of tinnitus in any individual. So with this, I will move to assessment, why and how. So we know that tinnitus is something which is in the brain. It is not somewhere in the ear, it is not somewhere in any other parts of the body. We can classify it saying that tinnitus is something that can happen within the brain. Okay, that will be a more appropriate way of representing tinnitus, or you can say tinnitus is in one individual's head, not ear otherwise. Okay. So now when we consider audiological assessment, we have to go for different types of assessment. You alone doing a routine audiological evaluation is not going to say what kind of tinnitus the person is having or how to quantify basically. You're doing some assessment, you have to quantify something, right? There is no point just saying that the individual is having tinnitus at this particular frequency. That won't be sufficient. So how much is the individual affected by tinnitus? So that information also should come in. So basically my talk will be covering these four aspects. The first one is about routine audiological evaluation. Then following that, we are going to talk about objective assessments that are there, and also psychophysical assessments of tinnitus, and also the significance of using certain questionnaires to assess tinnitus. So these four things will cover audiological assessment. So routine audiological evaluation, when we start off, we have to know that these things to be covered under routine audiological evaluation. So most of it you can see that these testings are done in a clinical practice by most of the audiologists. Like you will be taking a detailed case history, then you will be doing an otoscopic examination, you should be doing a Puritan audiometry, you have to go for extended high frequency audiometry. Why, I'll tell you in later, because that is giving some significant information. And then you can do speech identification scores, spin, speech and noise test, and loudness discomfort levels. So going to the first component, the case history. So case history, you have to collect the demographic details. Okay, you have to see for the individual's details with respect to the age, the gender, and the like. Also, you have to collect information about the occupational details. Here, the major highlight you have to remember is that occupational hazards can cause tinnitus. One of the most common reason for tinnitus is noise exposure. Individuals who are exposed to noise can be affected, or tinnitus can be one of the primary symptoms that can be indicating a hearing loss in the future. Tinnitus can happen with and without hearing loss also, but remember, this noise exposure is considered to be one of the most primary reason for generation of tinnitus. So in the question, when you ask, you have to clearly ask about noise exposure if an individual comes to you. And to make your life easy, there is already a ready-made questionnaire available. There are multiple questionnaires available. Tinnitus Case History Questionnaire. You can note down the name by Tinnitus Research Initiative in Germany. They have designed a questionnaire to ask for case history. I have the representation here. You can see there are a fixed set of questions, almost 30-35 questions. It will cover everything. So you don't have to be doubtful about what questions to ask, what significance it gives. You can just try downloading this questionnaire, and you can administer it, so that no major questions related to tinnitus is missed out. Even if you're going to any kind of management, it is good if you have information on these specific things. Later, if you want to assess and check how is individual's status, so this questionnaire might give or prove useful at that particular point of time as well. And now again, continuing with case history, you have to find out about the onset of tinnitus, since when tinnitus is present, the duration of tinnitus, the location of tinnitus, what is the type of tinnitus, whether it is continuous or pulsatile. And continuous or pulsatile, generally pulsatile tinnitus is a form of objective tinnitus, or I'll say it is due to generally blood circulation noise or breathing noises or the like. And subjective tinnitus or objective tinnitus, the difference is Dr. Rajeshwari told. Subjective tinnitus is when you perceive the tinnitus, and objective tinnitus is when somebody else is also able to hear the tinnitus when come closer to your ear. You also have to ask if the tinnitus is unilateral or bilateral. Here, a question you have to keep, remember that unilateral tinnitus is generally more dangerous than bilateral tinnitus. Why? Because unilateral tinnitus can be associated with a tumor also, or any such conditions that can happen in the auditory system. So that component you have to remember. You have to consider unilateral tinnitus as most urgent thing to be treated compared to bilateral. And in cases, we also have to ask about hearing loss. Is the individual having any hearing loss? Why this thing is important is that most of the individuals will start developing hearing loss at the age of 35 to 40 years, as early as that age, okay? As in when the age progresses to 50, 60 and all, there will be some amount of hearing loss that is, what can be seen in the audiogram, or when you talk to the patient, they'll be having understanding problems, etc. But here also you have to ask them, do you feel that you have any kind of hearing loss? That is going to give some indication about the source or generation of tinnitus, because if you have a hearing loss that is started already in the individual, that indicates that tinnitus can be due to the amount of cell loss that has happened already in the individual. Hyperacusis is an associated condition that generally accompanies tinnitus. You have to talk about that also to the individual. Dr. Prashant will talk in detail about hyperacusis. And vestibular disorders also, because the same blood supply, the fluid in the cochlea, all those components. If there is a vestibular disorder, that indicates that the cochlear system also can be affected. Medical history, you have to ask in detail if there are any medications that are being taken, or is there any other conditions that can affect individuals and cause tinnitus. The next component should be a case history that need to be taken with respect to psychological concerns. You have to ask about anxiety, you have to ask about depression, you have to ask about frustrations. So these components, now of late what we can see that the management line is shifting mostly towards having psychological basis in that. So when you consider that aspect, you have to mostly have these kinds of information also collected. I have given 2 questionnaire names. You can go through those questionnaires also. So those information gives, those questionnaires will give information on about anxiety and depression, etc. So if an individual is having associated anxiety or depressions, those individuals are going to be difficult to manage, because, and it requires, psychological form of management along with medical and audiological management. And that is about the case history. Let's see about rest of the aspects. Autoscopic examination can give good information, as we saw in Dr. Rajeshwari's presentation. impacted cerumen or ear fullness, otitis media, and any other forms of complaints which you saw in the previous presentation can be found out using otoscopy. So this is one indication that you have to do, okay, in clinical practice. We often don't see audiologists practicing doing otoscopy in private clinics. So it is better if we can get some information on, if tinnitus is caused due to some problem with the conductive system of the ear. And now going into pure audiometry, what extra do you have to do, or is it sufficient to do from evaluation from 250 hertz going up to 8000 hertz? So basically, your pure audiometry is going to give information on type and degree of hearing loss. Here, when we assess, we have to also keep into account about these factors. You do a pure audiometry, you'll get type and degree, but along with that, you have to see for symptoms of NIHL, where is a Fouquet notch. You have to see if there is a dead regions present, so you can do a 10 test if required. You can go for sloping hearing loss. If you what happens is generally individuals with tinnitus will have some form of hearing loss. Even if you say that their thresholds are normal up to 8000 hertz, there will be some hidden hearing loss seen in them. So sloping hearing loss may be up to 8000 hertz, or even after that is an indication of the reason for generation of tinnitus. That is definitely SL loss. Or Meniere's disease, as discussed by Dr. Rajesh some time back, that can be one indicator. And presbyacusis also. As in when hearing loss creeps in any individual, there can be maladaptations in the auditory system which can lead to tinnitus. So these factors also need to be taken into account when you're going for a pure tone audiometry. And as I told some time back, it is important to see that high frequency or extended high frequency audiometry is performed. Okay, this is a result from one of the studies we have conducted in the department. And here we can see that up to 8000 hertz, the thresholds are within normal. I haven't put that. But above that, you can see 10,000 hertz, 12,500, 14,000 and 16,000. You can see the thresholds compared to individuals who are having no tinnitus. There is elevation in individuals who are having tinnitus. So this can be one indication why tinnitus is generated. So even when you have to keep in mind, even when you have a normal threshold up to 8000 hertz, don't say that they have normal hearing sensitivity. Okay, it could be that they have hearing loss present at extended high frequencies, that is 8000 and above. Okay, so this, if you can test with supra threshold headphones, it is going to be beneficial. So keep that in mind. Okay, so supra threshold headphones, you have STA 200 headphones or some similar forms of headphones which are capable of providing stimulus up to 16,000 hertz. Your audiometer should also have the capability. So if you're not finding a reason why this individual is having tinnitus, the first step would be doing a high frequency, extended high frequency audiometry, and then finding out if the individual is having some amount of loss. Then going to other tests, spin, SIS and LDL. SIS is to be done, especially if they have poor speech identification scores, is an indication that they will have some amount of neuronal component in their problem. So this, if the scores are poorer, less than 75%, it is always good to go for detailed evaluations. Why? Because you can go for an ABR cytoplesion testing or recommend to a proper neurologist for evaluation. And spin scores again will give you, in case you have some individuals will have difficulty in understanding in the presence of noise. So that is again an indication. So spin scores also you have to check, preferably done at 0 dB SNR, and the score should be at least 50%, so that to indicate that the artery system is normally functioning. And LDLs, and so here there are questions that you have to keep. Hyperacusis, when it is there, you have to be careful doing all these tests, because these individuals can get disturbed if loud sounds are given. Also, these things can indicate RCP or retrocochlear pathology or cochlear pathology. You have to caution on that also. And also ANSD, auditory neuropathy spectrum disorders, that is when you can get poorer scores in speech identification as well as in spin. So those things are to be kept in mind when you are evaluating these individuals. And now going into LDLs. LDLs are important to be assessed, but provided you have to keep in account that misophonia or hyperacusis is taken into account. Misophonia is dislike to general normal conversation levels. It is not for extremely high levels, but hyperacusis is slightly different. It is generally happening at higher levels. Misophonia can be for a very soft sound also. One example for misophonia is somebody chewing on dining table when you're having dinner. That chewing noise can be considered as very much disturbing by certain individuals. So that is a misophonia. So when you're presenting sounds, these individuals, you have to keep in account that you're not affecting their loudness tolerance levels. And it is better to start in such cases at MCL level, that is the most comfortable level, and increase in 2 dB steps. And also you have to do extended high frequency LDLs if required. So that is about case history components and routine audiological evaluations that you need to be following. So I'll just recap the information what I told. You have to go for routine audiological evaluation. Considering the fact that they can have extended high frequency loss, it is good to do hearing evaluation at extended high frequencies starting from 8,000 onwards up to 16,000, provided you have a headphone that is functional for that particular thing, and the audiometer which has a facility. Then I told about speech identification scores. I told about SPINS tests that need to be done, and with caution you have to do all that, and also LDL need to be performed. And so now going into psychophysical assessment of tinnitus. So what tests need to be done to quantify tinnitus? So this is one of the most common ways followed internationally to assess the tinnitus. You have to quantify it, right? Now, when a patient comes to you, you cannot just say tinnitus is present. You have to say what is tinnitus, with ensure that you have clear understanding of pitch and loudness. You have to counsel the individuals about what is the difference between the pitch perception and loudness perception, because a layman will not be able to understand in the first instance what do you mean by loudness, what do you mean by pitch. So you have to give clear examples and then start off the procedure. So firstly, the pitch matching gives information with respect to the place of stimulation and rate of temporal coding. So here, when there is a change in the pitch of the tinnitus, this corresponds to the place of the stimulation related aspects of rate of temporal coding. So in the maximum amount of hearing loss. So now this is the reference frequency for loudness matching. So now you're done with frequency matching, you got the pitch of the tinnitus, but this serves as the reference for loudness matching. So how loudness matching is done? You are giving stimulus at 5 dB at that particular pitch as reference signal, and 5 dB above that particular threshold of the individual. So generally what you have to remember is that tinnitus is a range of 0 to 15 decibels on an average in any individual. Okay, that means the tinnitus loudness generally is up to 15. I have seen patients up to 35 dB also, but that is very, very rare. On an finding out pitch of the tinnitus and loudness of the tinnitus. The next component is residual inhibition. So residual inhibition is nowadays not much common because about the kind of techniques that they use. For example, if you're using TRT, you need not really follow about residual inhibition. But if you're going for masking methods, residual inhibition is going to be much useful, because this will give you whether the ear is sensitive to giving noise. Okay, that the noise that can mask tinnitus. Here the procedure is that where the tinnitus is present, in that ear you're going to give white noise at minimum masking level plus 10 dB. Okay, so if you remove the minimum masking level is also fine, but 10 dB above the threshold at that particular frequency, you are going to give white noise for a duration of 1 minute. So 1 minute you have to time it. At the end of 1 minute, if you find that tinnitus is absent, that is called as positive residual inhibition. If tinnitus is there but it has reduced, it is called as partial inhibition. If there is no change, it is called as negative inhibition. And if the tinnitus becomes more after giving the noise, it is considered as rebound. Okay, if the tinnitus perception becomes more. So if you take these two cases, the first two cases, the positive complete and positive partial individuals generally benefit from masking methods, and the other two, the negative and the rebound groups, do not benefit from masking methods. Those individuals have to go for TRT or any other psychological form of management. So that is about measuring residual inhibition. At minimum masking level, you can either use a narrowband spectrum or a broadband spectrum and find out what is the minimum level at which the tinnitus gets masked. Okay. And another psychophysical test that you can do is the PTC, that is psychophysical tuning curves. And I know if any would have studied, you would have thought like it's a very tedious procedure. But you always have the software PTC, which is a free downloadable version generated by Cluck and Moore. That is a free download. SWPTC, if you can Google it, you can download and use it by yourself. And this can give information in a much faster way, and you generally measure Q10 and tip frequency. So Q10 is generally indicated as the sharpness of the tuning curve. This is the sharpness of the tuning curve. And tip frequency is considered as what is the frequency of the tip. Here you can see it is almost close to 4000 Hertz. So if you do, for example, this particular test is done on a normal individual. So if you do it, for example, if there is a broadened Q10 that you are getting, if this becomes more broadened, that indicates there is some definite OHC damage, outer hazel damage. If the tip frequency is shifting from a particular frequency, that generally indicates more of a inner hazel damage. So you can find out, where the damage is also, but keep in mind, these are all additional tools that you can use. These are the things that you need not mandatorily use for identifying tinnitus. But these are additional tools that you can use in the clinics if you have time and facility to do that. Okay. For doing this, you just need to have a laptop. Nothing else is required. You can Google it, SWPTC. You can download it free and then use it. And so that is about psychophysical assessment. And if you ask me, this is one of the most important component of assessing the tinnitus, because psychophysical assessment will give you about what is the amount of tinnitus that the individual is perceiving. It gives you about the pitch of the tinnitus. It gives you about the loudness of the tinnitus as well. Okay, so those two components are covered. So now going to objective assessments. So under objective assessment, my concern is whether you all need to do this or not. But I would say that you need not do it if your aim is to make the individual better. But some instances, these are going to be useful because, if you're really not able to find out what is the cause of tinnitus generation, these tests are going to be helpful for you. Okay. The first one. Okay, so remember that if you go for a standard autoacoustic emission evaluation, you may not get any clear picture. But in literature, when we search, we can find that the DPOE amplitudes and contralateral suppressions are generally significantly lower in tinnitus. That means the amplitude of OEs are generally lesser. Okay, this is from a review article. So it is generally lesser. I don't say that, always you will get, the same result. So mixed results are reported in literature. And here also, we have used a, 50, fine structure, 50 points per octave OE analysis. You can see in the graph over here, to test between 200 Hertz to 16,000 Hertz. And we also got mixed results. You can see in the first on the right side, you can see there is a ripple width that is measured. In fine structure OEs, we do not measure the standard SNR. We are going to measure the number of ripples or the ripple height. So you can see the representations. It may be a little complicated for you all, but you can find out the number of ripples, the mean ripple width, and the ripple height. So here also you can see the black line indicates without tinnitus and the gray line indicates with tinnitus. You can see mixed results, across all the different kinds of tests. So there also it is not that you will be definitely able to find out some amount of problem that is there in the outer hazel. But literature reports that generally when there is a tinnitus, those individuals will have reduced amplitudes and contralateral suppression compared to other individuals. And contralateral suppression, as I told, again we got mixed results. In literature also gives mixed results. You can see the difference is there only at low frequencies. You could not get much difference at higher frequencies. Okay. So do you have to rely on autoacoustic emissions? I would say need not. But if you do it, you may get some indication that there is some amount of damage. Next is impetus evaluation. Tympanometry is a must. You have to go for tympanometry because all the ENT related aspect, which Dr. Rajeshwari said, most of it we can find out if there is a mid-ear problem or not by doing tympanometry along with reflexometry. But you have to be really careful about when you do acoustic reflexes. Why? Because it is not always recommended, because tinnitus can be associated with hyperacusis, as I told some time back. So if you do a reflex testing, maybe for example 90 dB, 100 dB, there are people who have very low levels of tolerance, for example 60 dB or 70 dB also. So if you're going to present and get a reflex at very high levels, that can cause distrust between patient and clinician. Remember that tinnitus patients are not individuals who visit you once. If you go for proper ways of management, they will be your patients for at least a year. If you follow TRT, they say 18 months. You go for other forms of management, psychological related, everything says at least 8 months to 1 year minimum. Okay, so if you suddenly during the assessment only give too much of noise to them, that can cause distress between you and the patient, and that should be avoided as much as possible. So do administer that if it is really possible to be done. And reflex decay also, again you're going to be giving much higher level, right? 10 dB plus in the contra year. So that is again going to be difficult. So they do it only if it is really feasible to be done. Some individuals having only pure tinnitus, you can go ahead, but keep remembering that hyperacusis need to be also kept in your mind when you go for this evaluation. ET function test, because many a times tinnitus is associated with malfunctioning of the eustachian tube. It can be a patelless eustachian tube. Sometime back Madam had explained about that. So there you can go for ET function tests also. Now, do you have to go for ABR? ABR is an indication, yes, if you have speech identification scores that are poorer, if you have vertigo, if you have dizziness and all those symptoms, it is always good to go for ABR testing for site of lesion purpose, not for any other purpose, not for finding out the threshold. You can go for ABR if you need to find out for site of lesion. Okay, there you can compare between a higher rate and lower rate ABR and then say if there is any indication, or if it is not possible to be done, if you find that there is some amount of neural component, then you can refer to a neurologist for further evaluation. So this is one study done here, and here you can see that everything is normal. This is with and without tinnitus, without peripheral hearing loss. You can see that there is slightly reduced amplitude in individuals with tinnitus compared to that without tinnitus. And the longer latencies and reduced amplitude of wave 1 is the general indicator. Dr. Ajit also told, where is the pathophysiology? Generally, it is towards the lower part of the auditory system, the higher auditory system. Okay, I mean to say the auditory nerve and onwards. So there, if it is, there is a problem, you generally tend to get a first wave that can be delayed or with reduced amplitude. So this is a wonderful article. If you want, you can go through it. This is again a review article. They have studied so many studies which are done in ABR and tinnitus, and most likely the conclusion is that there can be a longer latency and reduced amplitude for wave 1, but it is not very consistent. Remember that. And you have to constantly follow one methodology, otherwise you will be getting different results also. So now this is one recent finding that is there. So nowadays hidden hearing loss is becoming one of the most popular topics in audiology. People who are into research will know that. So here what you have to understand is that there are researches that is happening in rats, which say that cochlear inner hair cell ribbon synapses are found to be damaged in tinnitus, individuals who are having tinnitus and having peripheral normal hearing sensitivity. So even if you're not able to find any loss in the audiological evaluation, there is some amount of hidden hearing loss that could be due to a inner hair cell ribbon synapses or damage that can be seen in that particular regions. So that is about objective assessments. Objective assessment you have to go for, again I'm summarizing, objective assessments you have to go for impedance evaluation. Reflex, you have to be careful, or you have to be knowing that there is no hyperacusis when you're going for that evaluation. Okay, and you also can do eustachian tube function test to identify any problems related to the eustachian tube. And next is questionnaire based assessment. So now what information are you getting from doing all these three types of evaluation? You can just get to know that tinnitus is of this kind of levels. For example, I say tinnitus is of 20 dB at this particular frequency. How much is that affecting the individual? You will not have any idea. Okay, so that is most important, right? When a perception of the patient is most important. So what you have to really do? You have to ask the individual certain questions based on the questionnaires which are standardized, and then you can get to know how much is that particular tinnitus is affecting the lives of the individual. Okay, so this is the major concern why we have to go for questionnaire based assessment. If you want to really say tinnitus is severe, tinnitus is moderate, tinnitus is catastrophic, then you have to go for questionnaire based assessment also. So this I again explained. Okay, all these things are going to give the psychophysical measures, the pitch and loudness, and all the objective evaluations are not going to give you any specific information on how much is it impacting it impacts the life of the individual who is having tinnitus. In such a case, you have to go for questionnaires that can really give information on how much this tinnitus or this condition is affecting them. So now I'll introduce to you 3 or 4 questionnaires which are very commonly used. I'm not with the lots of questionnaires. You just give search as questionnaires for tinnitus assessment. You will be getting a lot of questionnaires that are there in the Google. So I would recommend you to go for something standardized. For example, this questionnaire, tinnitus handicap inventory, is one of the most popular questionnaire that is used globally, and it is very simple to administer. It hardly takes 5 minutes. Okay, these questions also you can see on the screen. If you're not able to see it, you can just Google for tinnitus handicap inventory or THI. Okay, and it is already translated into multiple languages, so country specific information also you may get. So you can just take that and give it to the person, and the individual has to read the question. First question, I'll just read it for you all. Because of tinnitus, is it difficult for you to concentrate? Okay, the individual has to say yes, sometimes, or no. Then you score it. In the bottom you can see the scoring. So if it is a yes, it is scores carries 4. If it is a sometime, it carries 2, and if it is a no, it carries 0 points. And in the end, you have to compile the score and see where the individual is. So if it is 0 to 16, it is slight. 18 to 36, it is mild. 38 to 56, it gives moderate, and 58 to 76, it gives severe, and 78 to 100, it is catastrophic. So here also you can see the description of it. And this questionnaire is well validated and is responsive and easy to score and interpret. So this will give you, for example, a score of 50. You can say that individual is having moderate amount of tinnitus. It is something like you're doing a PTA and you say the individual is having moderate hearing loss. So this will give you a quantifiable information as in how much amount of tinnitus the person is having, or what is the effect of tinnitus on the individual. Another one is Tinnitus Severity Index, or TSI, by Michael et al. So here it's a 12-item questionnaire. It also includes the effect of tinnitus on work, social activities, and overall quality of life. So same thing, you can see the question. One question I'll read: make you feel irritable or nervous. So you can just see never, rarely, sometimes, usually, and always. So here you can receive scoring like this. If it is 1 to 12, points are classified as mild. If you get 13 to 24 as mild, and 25 to 36 as moderate, 37 to 48 as severe, and greater than 49 as catastrophic tinnitus. So this also gives you information on how much amount of problem the person is having. The next most popularly used questionnaire is Tinnitus Functional Index. Okay, this is a comprehensive coverage of multiple domains of tinnitus severity. It's a 10-point rating scale, and it also gives sometimes about the percentage of the problem. So it's a 10-point rating scale, and the mean score of 14, a range of 0 to 17 is not a problem at all. It's of 21, a small problem. 42, it's a moderate problem. 65 is a big problem. 78 is a very big problem. And another way of classification is, if you don't want to complicate too much, you can take it as less than 25. Mild tinnitus, it need not go for intervention. 25 to 50, a possible need of intervention is there, and greater than 50, it is severe tinnitus, and you have to go for aggressive modes of intervention. Okay, so these ways you can also see and understand if an individual needs management also. Okay, so keep these things in mind. These are very simple forms, and you can easily assess, and it hardly takes 5 minutes for each questionnaire. So this is how the questionnaire looks. You have, the questions in percentage or sometimes in 0 to 10, or you can rate it as 0 is 0% and 10 is 100%. So the questions are there like that. You can just go for, assessing through questionnaires also. And these are the 9 widely used questionnaires that are there. And 4 I've given, 3 questionnaires I've already explained to you. Other questionnaires are also there. You find if it is suitable for you all, you can use these as well. So the last component is going to be a tinnitus holistic simplified classification. So here, so now you know that tinnitus requires ENT assessment and management, audiometric assessment and management, or somatosensory assessment and management. Okay, so this particular thing is a holistic procedure because you're not only seeing for ENT related problems or audiometric related problem, audiology related problems, you're also seeing for somatosensory based problems as well. Okay, and you also have a self-assessment questionnaire that need to be used along with that. So here, what do you mean by somatosensory basis? So here the head and neck and TMJ maneuvers are used also to highlight the changes in pitch of the tinnitus, loudness and lateralization. So temporal mandibular joint, you know that, when you open the mouth or close your mouth, move your head, move your neck, all those times, sometimes what happens is, if you would have seen patients, some individuals are going to be having fluctuation in the tinnitus, what they perceive. Okay, so if you do the assessment through this particular tinnitus holistic simplified classification, is going to be beneficial because it tells you what form or what kind of assessment you need to do. So now first step is basic audiological assessment. So basic audiological evaluation, if you go for and you find that there is some amount of hearing related problems, it is considered as a auditory tinnitus. And if you go for somatosensory investigations, that is basically movement of the jaw, opening of mouth, etc., turning of your neck. There are certain structured ways. You can just go search for THOSC. It is given in detail in that. And if you find that there is change in the perception of tinnitus, it is considered as somatosensory tinnitus. So if it is a somatosensory tinnitus, you have to follow that particular pattern of management. Another thing is that if you have psychiatric investigations and THR related investigations, if you can do, so that is psychopathology related tinnitus. So this is nothing but a combination of audiological, ENT related and psychological related tinnitus. And if you find any 3 forms here, you can classify basically whether it is auditory, somatosensory or psychopathology related. So then further psychological management need to be done, or if you have somatosensory tinnitus, you can go for ENT management, and if it's auditory tinnitus, then you have to go for audiological related management. So these are the ways in which you can really holistically approach tinnitus, not just going by one form of evaluation. Always remember that one form of evaluation may not give you proper results. You have to combine other forms and then do the assessment. So I conclude here because we are already late, and I'll give you some take-home messages. So tinnitus can be a symptom of a serious underlying pathology and hence need appropriate assessment. This is especially true when you have some neurological problems associated with it. You have a space occupying lesion, you have to be more cautious. You have giddiness, you have associated problems like that, you have vision blurring, etc. and associated tinnitus, you have to be really watchful and then send for detailed neurological assessment as well. And there is no definite cause-effective relationship that can be established in subjective tinnitus. Sometimes you may not get any reason also why tinnitus is generated. And tinnitus may not always be associated with hearing loss also. I told you hidden hearing loss is one of the concerns currently. So you may not get, what is the reason for that. And the assessment of tinnitus should focus on deriving at selective and effective management options. Just doing an evaluation is not going to be beneficial. Why you want to do it? What is the line of management? Sometimes if you have an accompanying hearing loss, remember that giving a hearing aid is going to be beneficial. Why? Because if you have a peripheral loss means if you have a cochlear loss, and if you're giving an amplification to the individual, and if the individual is benefiting from the amplification, generally what happens, the maladaptation that has happened in the brain or causing tinnitus would get broken. If that is the case, you will naturally feel better and you will not perceive tinnitus if you were hearing it for a considerable period of time. So why you are assessing all this is basically for effective management options. So keep that in mind. Don't just do an assessment and leave the patient. So that is what generally happens. Most of you will be knowing to do a pitch assessment and loudness matching. But is that the end of it? No. That is just the beginning, because you have quantified tinnitus. You have to plan effective management. And tinnitus may be associated with hypacusis or misophonia, and hence considering this while doing assessment is important. So again remember that it can create distress if you are giving too much of sound, and if the individual gets disturbed, it is going to be a big problem. So do not do such evaluations if it is not able to be done because of tolerance related problems. Okay, so I will conclude. Thank you. And discussion, you can type in the questions as we are running behind the schedule, and then I'll try to answer them later. Or if I'm not able to answer here, we are noting down the questions and then we will email to the concerned person. Okay. So thank you everyone for your patient listening. Thank you.